The purpose of this video is to highlight the physical exam findings that can be associated with respiratory distress. Before we meet your patients, let's talk about respiratory distress, which can occur when there is poor gas exchange, causing decreased ventilation and oxygenation. Respiratory distress can be characterized by a patient's general behavior, work of breathing, respiratory rate, oxygen saturation, and feeding status. These characteristics can be noted during your physical exam and from the patient history. When assessing a patient's general behavior, you are checking if a patient is still playful, tired, or lethargic. Lethargic is a word that may be used freely by some of your patients' families. It should be used specifically when your patient has limited responsiveness and her speech and movement is limited. The child will respond to stimulation but will fall back asleep. Sometimes you may need to sternal rub a patient in order to arouse her. A child that is looking for her parents or crying when you examine her is not lethargic. Assessing behavior can be subjective. The more tired your patient is, or if she appears lethargic, you should be more concerned about the severity of her illness. You probably have heard the term work of breathing as a general term used when a patient is using accessory muscles to breathe. Patients use accessory muscles to help increase tidal volume when they are breathing quickly due to their illness. When you assess a patient and describe your findings, you can use more specific terminology describing if the patient is retracting, nasal flaring, or grunting. Infants and young children have more compliant chest walls, which is why you are more likely to see the use of chest wall muscles to aid in respiration when in distress, as compared to older children and adults. Accessory muscles that can be used when a patient is in respiratory distress include subcostal, intercostal, or suprasternal muscles. The further up the body the retractions are seen, the more distress your patient is in. You can also grade the retractions as mild, moderate, or severe. However, this grading is subjective, and the more patients you see, the more you will develop a sense of how mild or severe a patient's retractions are. Nasal flaring and grunting indicate that the patient is in more severe respiratory distress. This is a clip of a patient with nasal flaring. Do you notice her nares moving? This is a clip of a patient grunting. Sometimes this noise can be mistaken for crying. An additional sign of severe respiratory distress is head bobbing, such as the patient in this clip. While you are observing your patient's work of breathing, also note any central cyanosis, where the lips and tongue are blue, sometimes in addition to the hands and feet, such as what you can see in this clip. You should also ask parents about if the patient has been drinking fluids normally and has normal urine output, for example, normal number of wet diapers. Part of your physical exam will help determine the hydration status of your patient as you check capillary refill, skin turgor, and dry versus moist oral mucosa. Here's a table to help guide you when identifying respiratory distress. Please note that this guide is not a validated system to score respiratory distress. Note that oxygen saturation is below 88% and respiratory rate greater than 70 breaths per minute indicates severe respiratory distress. In general, the more severe distress a patient is in, the more sick they are. For example, a patient with moderate retractions in 3 muscle groups with hypoxia and not tolerating oral intake can be considered more sick than a patient with mild subcostal retractions with normal urine output. Every time you walk into a patient's room, based on your observation and exam of the patient, think about how sick the patient appears. Bedside assessment of vitals, general appearance, mental status, and lung exam allows for rapid determination of the severity of illness and interventions needed to reverse the course of illness and prevent respiratory arrest. Now let's meet Aiden, a 15-month-old infant with no significant past medical history. His parents report that he has been having about 3 days of rhinorrhea and congestion, but no fevers. He has been having more trouble breathing and is breathing faster. His parents are also worried because he hasn't been drinking formula like normal and has had fewer wet diapers. Do you think Aiden appears sick? Watch his breathing and note his vitals. Does he seem to be in respiratory distress? Aiden has moderate subcostal retractions, and his respiratory rate is increased to 66 breaths per minute. His oxygen saturation is, however, greater than 88% at rest. He would be considered to be in moderate respiratory distress due to his retractions, tachypnea, and oxygen saturation. You check on other patients, and Aiden's nurse says that Aiden is looking worse. What's your assessment as you walk into his room this time? While he is not toxic appearing, he is appearing sicker. You also note that now he is having moderate supraclavicular and severe intercostal and subcostal retractions. You look for nasal flaring and listen for grunting. Do you notice these findings on Aiden now? Although he is not nasal flaring or grunting, he is in moderate to severe respiratory distress and will require additional support, particularly heated high-flow nasal cannula for what is likely bronchiolitis. Now let's go see your patients in the asthma room because it's almost winter and the breezes just keep coming. Sophia is a 2-year-old female with past medical history of asthma and allergic rhinitis, who presents with 2 days of difficulty breathing after having 3 days of URI symptoms. She is here for an asthma exacerbation. What is your assessment of Sophia? On your lung exam, this is what you hear. Sophia has mild to moderate subcostal, intercostal, and suprasternal retractions, and you can hear end expiratory wheezing throughout the lung fields. She is in moderate respiratory distress. One thing to keep in mind when performing the lung exam on asthma patients is that not hearing wheezing could indicate poor air movement. You should listen closely for any air movement. Wheezing can only occur if there is air movement. Finally, you've reached your last patient of the day. Naturally, he's another breather. Danny is an 18-month-old male with no significant past medical history who presents with 1 day of rhinorrhea and nasal congestion. Parents note that he was making a funny noise when breathing today. What do you note during your exam? Do you consider Danny sick or not sick, and is he in respiratory distress? His parents tell you that he is making that funny noise now. What you are hearing is stridor. He has mild suprasternal and subcostal retractions and is in mild respiratory distress. Given his barky cough, stridor, and URI symptoms, his diagnosis is croup. Thank you for watching this video. If you would like further information on bronchiolitis, asthma, and croup in pediatric patients, the following articles provide a good review of these conditions.